Good morning, good afternoon, good evening, wherever you are. Welcome back to Virtual Grand Rounds. This week, it's a great delight for me to present Professor Yasuhiro Tsutani, someone who's very well known in this space, involved in a lot of trials with actionable genetic mutations with resectable lung cancer. This week, as always, it's Premier Education brought to you at no cost, thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. And without further ado, Professor Tsutani, over to you.
Yeah, thank you, Professor Lim. It's my great honor to be here. Today, I will discuss adjunctive systemic therapies in stage 1 non-small cell lung cancer and how we should move from no standard era toward a truly personalized treatment strategy. Stage 1 non-small cell lung cancer has traditionally been considered a surgical disease. However, as shown in these disease-free survival curves, outcomes are not always satisfactory, even in stage 1. This suggests that a subset of patients may still require systemic therapy to reduce the risk of recurrence. First, I represent the global evidence. The CLGB 9633 trial was a randomized study comparing surgery alone with adjuvant chemotherapy using a carboplatin and paclitaxel in patients with a stage 1B non-small cell lung cancer. However, the results were negative in the overall population. In the subgroup analysis, potential benefit of adjuvant chemo was suggested in tumors greater than 4 centimeters. However, according to the current TNM classification, tumors rather than 4 centimeters are categorized as stage 2A. Therefore, there is no clear evidence supporting adjuvant chemotherapy for stage 1 disease at present. In contrast, there is a unique evidence from Japan. The JLCRG conducted a randomized trial comparing surgery along with adjuvant UFT in patients with pathologic stage 1 lung adenocarcinoma. UFT or tegafuracil is an oral fluoropyrimidine agent. In this trial, adjuvant UFT significantly improved overall survival with a hazard ratio of 0.71 and absolute 5-year overall survival benefit of approximately 3%. This is a meta-analysis of adjuvant UFT trials. A total of 2,003 patients from 6 randomized trials were included in the analysis. Overall survival was significantly better in the UFT groups compared to surgery alone, with a 5-year OS rate of 81.8% versus 77.2%. This meta-analysis confirmed the efficacy of UFT, mainly in stage 1 non-small cell lung cancer. In subgroup analysis, UFT showed a consistent survival benefit regardless of age, sex, histology, and T descriptor. When stratified by histology, the hazard ratio for overall survival was 0.69 in adenocarcinoma and 0.82 in squamous cell carcinoma. These findings suggested that magnitude of benefit may differ by histology. Based on these data, UFT is strongly recommended for adenocarcinoma and weakly recommended for non-adenocarcinoma in Japan. These data show the effect of UFT in stage 1A tumors. No overall survival benefit was observed in tumors less than 2 centimeters, whereas clear survival benefit was seen in tumors 2 to 3 centimeters in size. Based on these findings, the Japanese guideline recommended the UFT for stage 1 tumors rather than 2 centimeter. Now we use the ninth TNM edition of the TNM classification. Since the 8th edition, tumor size has been redefined based on the solid component on imaging and the invasive component on pathology. As a result, previous evidence of adjuvant therapy cannot be directly applied to the current staging system. For example, tumors larger than 2 centimeters with minimal or no solid component are still candidates for UFT in Japanese guidelines. However, these tumors are indolent and rarely recur after complete resection. Therefore, we need to redefine the indication for adjuvant therapy in this new TNM era. This clearly indicates that stage 1 non-small cell lung cancer is a heterogeneous disease. It includes indolent tumors with almost no risk of recurrence, as well as aggressive tumors with substantial risk. Therefore, a one-size-fits-all approach is no longer appropriate. We performed a retrospective analysis of a prospective JCO 0201 cohort with over 10 years of follow-up. Pathologic stage 1 cases were reclassified using the current TNM system, and risk factor for recurrence were identified. Invasive component greater than 2 centimeter, vascular invasion, and visceral pleural invasion were significant risk factors. Based on this, patients were stratified into high and low risk group. Survival was clearly separated with a 10-year overall survival of over 90% in the low risk group. These results suggested that adjuvant therapy should be considered for high-risk stage 1 patients. So these data clearly indicated that treatment for stage 1 non-small cell cancer should be risk-adapted. This is another retrospective study of pathologic stage 1 non-small cell cancer after lobectomy or more extensive resection. Patients were stratified into low and high-risk groups, and the efficacy of adjuvant chemotherapy was evaluated. In the low-risk group, outcomes were excellent, regardless of treatment. In contrast, the high-risk group, adjuvant chemotherapy significantly improved recurrence-free survival compared with surgery alone. These results support considering adjuvant chemotherapy for high-risk stage 1 patients. Next, we evaluated the efficacy of adjuvant chemotherapy in high-risk stage 1 adenocarcinoma by EGFR mutation status. We analyzed 475 patients who underwent lobectomy. Patients were classified by EGFR status, and survival was compared between those with and without adjuvant chemotherapy. In EGFR negative or unknown patients, adjuvant chemotherapy significantly improved recurrence-free survival. In contrast, no benefit was observed in EGFR mutant patients. Therefore, EGFR mutation status may help guide the selection of adjuvant chemo in high-risk stage 1 non-small cell lung cancer. And finally, I'd like to introduce ongoing clinical trials. Ongoing trials are now targeting high-risk stage 1 disease using molecular and immune-based strategies. ADORA-2 is a randomized trial of adjuvant osimertinib versus placebo in EGFR mutant pathologic stage 1A2 to 1A3 non-small cell lung cancer. Both lobectomy and segmentectomy are allowed. The primary endpoint is disease-free survival in high-risk patients, defined by invasive size over 2 centimeter, lymphovascular invasion, or high-grade histology. Accrual has been completed, and we are awaiting the results. TROPION-Lung12 was an adjuvant trial for patients with high-risk stage 1 lung adenocarcinoma, excluding EGFR and ALK alterations. It compared the standard of care with a combination of DATO-DXd, TROP2 directed antibody drug conjugate, and rilvegostomig, bispecific antibody targeting PD-1 and TIGIT, as well as rilvegostomig monotherapy. High-risk status was defined based on the ctDNA and pathological factors. Unfortunately, the trial was terminated early due to poor accrual. The INTERPATH 14 trial is an upcoming study, and it's listed on clinicaltrials.gov. It targets patients with high-risk stage 1 non-small cell lung cancer, excluding those with EGFR and ALK alterations. High-risk status is defined based on the pathological factors only. This trial compares placebo with personalized messenger RNA vaccine V940 plus pembrolizumab or V940 monotherapy. The primary endpoint is disease-free survival. These efforts reflect the move toward personalized treatment strategies for high-risk stage 1 non-small cell lung cancer based on driver mutation status. Finally, I will introduce our phase 2 potential trial of neoadjuvant nivolumab in high-risk clinical stage 1 non-small cell lung cancer. High risk was defined as a pure solid tumor or solid component of 2 to 4 centimeter, excluding EGFR and ALK positive cases. Patient received 3 cycles of nivolumab, followed by lobectomy. The primary endpoint was PCR rate. Actually, 52 patients were enrolled, and all patients underwent complete resection in this study. So neoadjuvant nivolumab is very feasible for stage 1 non-small cell lung cancer patients. The PCR rate was 23.1%, exceeding the predefined threshold and meeting the primary endpoint. While longer follow-up is needed for recurrence-free survival, these suggest a potential role of immune checkpoint inhibitors in driver-negative high-risk stage 1 non-small cell lung cancer. This trial represents proof of concept for neoadjuvant immunotherapy in early-stage high-risk disease. So finally, this is the take-home messages. Stage 1 non-small cell lung cancer is a heterogeneous disease, and a one-size-fits-all approach is no longer appropriate. Risk stratification based on pathological and molecular factors is essential to identify patients who may benefit from systemic therapy. Uh, Personalized perioperative strategies, including targeted therapy and immunotherapy, represent the future direction for high-risk stage 1 non-small cell lung cancer. Thank you for your attention.
Excellent. Thank you very much for an amazing presentation and also for your leadership in developing the next generation of new studies. Maybe I can start with an opening questions. In stage one, you've correctly identified there is a real need to improve the outcomes of our patients. Adura 2 is an example of a really a phenomenal study in that
Mm.
um, the hazard ratio for Adura itself was almost 0.14. So you get an 80% reduction in
Yeah.
disease-free survival. The survival with one stage one is so good that that 80% can, really achieve a difference in stage one. Do you think that the mRNA vaccines or immunotherapy will have the same gradient of effect in stage one? Because I think Adura 2 will be successful, but unless you can get really, really low hazard ratios, I'm concerned that the impact won't be seen on stage one disease.
It's very important question, and V940 is still ongoing for stage 2 to 3 patient, and I have no results. But if the vaccine is effective, it's also effective for stage 1 disease, I believe.
Yeah, so the most of the immunotherapy or neoadjuvant, adjuvant, the hazard ratios have been around maybe 0.65, and that's quite
Yeah,
far
yeah,
away from 0.14. So
yeah.
I am also very interested in the outcome or results of these studies.
Mm.
At the moment in Japan, is it true that only UFT is licensed in stage one disease?
Yes.
And who administers the UFT? Are surgeons able to do you surgeons give it or oncologists give it?
Yeah, I think most of hospitals actually surgeon give the UFT uh, because that's an oral anti-cancer drugs. Uh, so for maybe for stage 2 to 3 patients who need platinum doublet therapy, maybe medical oncologists do that.
Yeah, so that's so amazing. That's so interesting because many Western centers around the world, surgeons are not allowed to give any form of systemic therapy. But
Oh,
in Japan, in China, the surgeons are giving the UFT. So can I ask for osimertinib, do surgeons administer osimertinib in Japan?
uh, uh,
For
uh,
osimertinib for
what
EGFR positive
else?
disease?
Depend on the institution, but in my hospitals, we thoracic surgeon do that in the adjuvant osimertinib. Yeah.
So the surgeons give it as well, right? I know. So
Yeah.
when I suggest this in the West or in the United Kingdom, people look at me like I'm crazy. Like how dare you even try to suggest this? And when you have countries where this is so established, this is great. I've got questions from Dr. Mahmood who's asking, when you operate now, right, you can see patients at high risk and low risk for stage one. Apart from UFT, if you are a high risk patient, are there any other options that that you give?
Um, Maybe protein doublet is also reimbursed in Japan. So, but UFT is a less toxic drug, so we prefer UFT.
Understand. Um, Mr. Marchbank is asking a question. Must you get molecular diagnosis for all your patients before you start the surgery now? Do you have any instances in Japan where you go to an operation with a suspected lung cancer and then take it from there?
We always examine the molecular diagnosis for stage 2 or 3 patient, but for stage 1 disease, we do not that pre-operative.
Right. So it's possible that you can take a patient to theater without a confirmed diagnosis of lung cancer,
Not always.
but sometimes you do.
So yeah.
Okay. And
So
in those,
after operation, we test EGFR or and ALK for stage 1 disease.
mm, but at the moment, neither EGFR or ALK is licensed for stage 1 disease. Is that right?
It depends on the area in Japan, but in
Oh.
Osaka, it's okay to test EGFR and ALK for stage 1 disease.
And if you have stage 1 disease and EGFR is positive, you can give osimertinib?
No,
All right.
in Japan, no, osimertinib is not reimbursed in stage 1 disease. Even for stage 1B disease, Japan not is not approved. Yeah, osimertinib. So, but so UFT is maybe not effective for EG5 mutation patients. So we just observe for such kind of patient.
Understand. So can I ask just a little bit more about the adjuvant treatments for your patients? So if surgeons can give UFT, surgeons can give osimertinib, where does it stop? The intravenous medications, immunotherapy, surgeons presumably do not give immunotherapy in Japan.
It's also depend on the surgeon. So
Oh,
we in Kindai University, we thoracic surgeon do the uh, immunotherapy. Uh, Even for the neoadjuvant settings, surgeon do that. Yeah. But
wow.
in another hospitals, maybe medical oncologists do that.
And
Yeah,
the surgeons handle the complications from the immunotherapy and the targeted treatment as well?
yeah,
Okay, so you manage the rash, you manage anything, thyroiditis, all that, you manage it all.
yeah. But basically we manage, but we sometimes consult pulmonologists and so on. Yeah.
Excellent. But you will also be in the best place to evaluate the safety, for example, of surgery. So if you give IO post-op, presumably you give neoadjuvant IO as well,
Yes.
right? So
Um.
this
Yeah.
the surgeons give the neoadjuvant IO and then evaluate the safety for the operation, gives the conducts the operation, and then presumably, if required, gives the post-operative IO as well.
Mm.
That's
Yeah.
in, that's incredible. And can I ask, why is there a variation in Japan of some surgeons who do and some surgeons who do not administer systemic treatments?
I don't know, but originally I'm a surgical oncologist at the time of start surgeon. But so I actually treated many patients. Uh, so breast cancer and gastrointestinal cancer, and actually give chemotherapy for that patient. So I personally familiar with chemotherapy. Yeah.
Excellent. And is it a different training program to become a surgical oncologist as opposed to a surgeon that just operates on cancer patients?
Yeah, maybe the different program. So some thoracic surgeon only do the surgery and not do the systemic therapy. Yeah.
Okay, excellent. Dr. Oloyi is asking, do you use ctDNA to help stratify patients into high or low risk after surgery to decide on adjuvant therapy at the moment?
Yeah, actually, we do not that. So there is no established ctDNA system. So yeah, but in the future, I hope to use that.
We've got a question from Dr. Sasi who's asking for stage 1 patients with UFT or any other adjuvant systemic treatment, how long do you give it for?
For UFT, actually, 2 year. for 2 years.
Two
It's a
years.
standard. Yeah.
Okay. And I presume you as a surgeon follow up these patients as well.
Yes.
And what is your follow-up regimen to look for recurrent disease? Would you do 6 monthly CTs or how do you decide?
Uh, Actually, CT scan for 6 months, every 6 months.
For how
It's
long?
a maybe standard. 5 year,
And after five
5 year,
years?
and after 5 year, annual CT scan.
An annual CT scan after 5 years.
Yeah,
Wow, that's
yeah,
incredible. Really well done. Congratulations. So glad to have you on board this week and to listen to a completely different culture, with a different practice compared to the rest of the Western world. I just want to, thank you once again for your leadership in this field. I know that you're going to be the principal lead author for the Adura 2 study, and we all are going to be looking forward to the results of that. Next
yeah.
week is the AATS, so we won't have a meeting. And for us, we'll be back on the 8th of May with Professor Amanda Tuffman talking about BRAF therapies and evidence and future directions. Leaves me once again to thank our sponsors, Medtronic, AstraZeneca, and Medela, the Science of Care, and especially to you, Dr. Sutani, for leading the world in this field. Thank you very much for your
Yeah,
presentation
thank you
today.
very much.
Goodbye.
Bye. Bye.